Good morning. It's Friday, December 3rd. Welcome into the Morning Medical Update. Thanks so much for joining us here on Facebook and on our YouTube channel. Glad you're with us today. So back by popular demand, all the way from back to yesterday, Dr. Damien Stevens is back. We had so many sleep questions, sleep apnea, CPAP machines, all things sleep that we just couldn't get to all of them. So Dr. Stevens was so nice to join us for round two of our sleep discussion. How are you today?
Thank you. I'm rested and ready to go.
Well, I said, can you come back tomorrow? And I wasn't kidding around. So we needed it. So thank you so much for being here with us. We're going to get to that in just a moment. Also, it's the best gift you could give this season, the gift of life. The gift of donated blood. The Community Blood Center needs 600 units of blood each day to service 70 counties in eastern Kansas and western Missouri. The supply is low and the need is great. We're going to tell you how and where you can help out. So make sure to get your questions sent in, sleep questions, blood questions, COVID questions. You can send those via YouTube, Facebook, Twitter, and the Medical News Network. You can find links to those right here on your screen. But first, the man who can do his job from anywhere in the United States. Yes, Dr. Dana Hawkinson is in sunny Florida this morning. Not so sunny where I'm seeing you at, but you've got our COVID count all the way in Florida. How you doing?
Yeah, I'm good. It's warm here. You know,
I was expecting to see the beach or something exciting behind you on this Friday, but
yeah. I'm
you can't get away.
Beach. I'm in the middle of the state. Yep.
Okay. All right. So what do you got as far as a COVID count?
You know, the infections, the hospitalized infections are going up. We have 31 active infections right now, 8 in the ICU and 7 of those patients on the ventilator, so a high proportion. Only 6 of those 31 total active infections are vaccinated. And we do have 16 additional patients who have met that removal of isolation, that recovery period criteria. So total of 47, but again, 31 active infections. It has gone up significantly within the last 7 to 10 days at our hospital.
And Dr. Hawkinson, I mean, what do you make of those higher numbers? I mean, what are your thoughts on that? Kind of help us understand what that really means. What concerns do you have?
Yeah, you know, again, this is before we've identified any Omicron here in the metro community. We know that there was now a new rise in cases from that Delta surge. We know that our lowest number of 7-day rolling average of cases never got to where it was in the past prior to, like a year ago, where we had a very, very low number of 7-day rolling average cases. But now, for the past couple of weeks, we certainly have seen a rise in our cases in the metro area. This is a function of that rise. We know that hospitalizations tend to lag behind cases by 2 to 3 weeks, and I think we are seeing the results of that that increase in the number of cases that we've identified.
So what's travel been like? I know you had this trip planned before Omicron hit. So just what was it like, people taking the right precautions? I know you always do it right, but were other people doing the same?
Yeah. Again, I think it is a great mandate or restriction that in those federal areas, such as airports, that masks need to be worn. We know that all the airline companies back masking and all that. So really on the planes, in the airports, everybody has masks for the most part, unless they're eating or drinking. Certainly some are always down below their nose. But I think we just have to all understand and realize that when you go to those places where you are around a lot of people, you have to believe that somebody has active coronavirus infection. Hopefully they're vaccinated, but you also have to assume that not everybody's going to be vaccinated. So you really have to protect yourself. I know that I wore visors, eye protection on the plane, as well as the mask. I would encourage anybody to do that who is going to be traveling for this holiday season. That is just one more layer of protection. And of course, if you haven't gotten your booster shot yet, or any vaccine yet, please go get those vaccine doses. But again, if you're traveling by air, it's fairly safe as far as the mandates. Everybody in the airport is wearing masks, so I think that helps a lot.
Yeah, same advice you always give. All right, so stay tight. We're going to get to some questions here in just a few moments. Let's just check and see if we have any reporter questions on the line first today. Okay, we good? We're good. Okay. So I want to turn to our other virtual guest this morning, Chelsea Smith with the Community Blood Centers. Good morning to you. How are you?
I'm great. How are you?
I am good. All right. Let's just jump right in. Set us straight. What is the supply like now?
Unfortunately, it's not good. We have been in a blood shortage for 19 months. Every month of the pandemic so far, we've been at better levels than we are today, though. So right now we're sitting at about a 1 to 2 day supply of blood types overall, which is incredibly low. So we do plan to go public with a blood emergency appeal on Monday, first thing. So we're hoping that the weekend will bring a boost in blood donations, but right now it's at emergency levels, unfortunately.
All right, let's get a jump start on it. That's why we have you on today for sure. So when this supply is low, explain to people what this means to our hospitals, our communities, and potential patients that may need blood.
Yeah, so right now what we're seeing also is an increase in hospital usage because still doctors are working through a backlog of patients that were kind of put on hold when we were in the thick of things in 2020. So hospital usage is up, donations are still down. So what that means is that we don't have a readily available supply. So if a trauma were to come in that requires a mass transfusion or something along those lines, it could very easily wipe out our blood supply in an hour. It gets incredibly touch and go when we are this low, and it affects our hospitals and their ability to treat patients. So we're trying to prevent it from getting to the point where doctors have to make decisions about who is getting treatment and who isn't. But the reality of the situation is that's what would come if our blood supply doesn't increase.
All right, so tell us who is eligible to donate, how they can donate, what people need to know before they come in and donate. Kind of run it down for us.
Sure. So blood donation takes about an hour. Most people actually can donate blood, but kind of self-defer, maybe because you're on a medication that you assume would defer you from donating. One big miscommunication that's been happening over the past year or so is that if you get a COVID-19 vaccine, a lot of donors are assuming that you can't donate, and that is not true. You can donate regardless of your vaccination status, so I need you to know that. Also, you can make appointments at any of our 7 donor center locations or our community blood drives. You can make those online at savealifenow.org.
Okay, so hang tight. We may have some questions from the community for you. And then at the end of the show, I want you to remind everyone where they can go. So let's get the word out throughout this program. Okay, so we want to get to some community questions because we only have Dr. Stevens for a short time today because he's got to get to patients. So we will get going on those. But I do have one for Dr. Hawkinson. She said, Joanna's asking, they're planning a trip to Florida in March. What's masking like in Florida that you're noticing?
Yeah, there's no masking. I do see some certain individuals, on an individual basis. Again, I'm here for a soccer tournament for my son, so there are people from all around the country here. So there are groups of people and families who are in mass, but in general, there's not a lot of masking. We are going to be doing activities outside. On the soccer field, so that will be safe. But otherwise, if you go into stores or a restaurant, obviously there's not a lot of masking. But I don't think that's a lot different from Kansas City either. So I wouldn't say there's too much difference.
All right, good to know. Thanks for that update. Janet is asking, is there going to be an update with other hospitals in the area coming up soon? And the answer is yes. That will be on Tuesday. We will have all the chief medical officers joining Dr. Stites to give you an update across the metro. So please stay tuned for Tuesday. There is a question for you, Dr. Stevens. Kathy says she's had a sleep test. They didn't find any sleep apnea. So now what?
It really depends on what specific signs, symptoms, and what they were testing you for. If they were specifically looking for sleep apnea, a sleep study does typically exclude or rule that out, but there's dozens of other sleep disorders that they may be looking for, leg movements, acting out dreams, even looking for narcolepsy, which is a form of sleepiness. So it really would depend on exactly what sleep disorder they were looking for.
Okay, question from Amy is, what is the correlation between lack of sleep and good sleep to Alzheimer's? Do we know?
We don't know exactly. That's kind of a relatively new area of sleep medicine that's been a lot of research dedicated to the last 5-10 years. What has been shown is patients that do report decreased sleep, sleep fragmentation, poor sleep quality, that kind of just in general, quote, poor sleep, there seems to be a higher rate of Alzheimer's in that population. The difficulty is sorting out, are you sleeping poorly because you are starting to have early signs of Alzheimer's? So it's this bad sleep is simply a manifestation that you are developing the stages of Alzheimer's versus is it the bad sleep that causes the Alzheimer's? And that's going to be very difficult to sort out entirely because it's not like you can take a group of patients and separate the two and see who develops and who doesn't. But physiologically it makes sense because what we really think happens during sleep is your brain kind of, quote, recovers, rest. There are studies looking at brain chemistry, and whenever you do sleep, there's clearance of some proteins in your brain. So physiologically, it makes sense that if you decrease that time or limit that time that you can, quote, kind of clean your brain, could you have a higher chance of developing Alzheimer's? But we just don't know for sure at this time.
Do you think it's a fair statement, though, to think that sleep is somehow connected to really all aspects of health?
That's kind of why I got into sleep itself. Where there's really no area of sleep medicine up until the last 30, 40 years, which is interesting because if you think about it, we're spending about a third of our life sleeping, but it's one of the newer areas of medicine that we've looked into research-wise. That's also the interesting part of sleep medicine because you're overlapping with cardiologists because there's heart rhythm issues, heart failure issues in sleep, psychiatrists. We've already talked a little bit about the mood disorders, the pulmonary. The reason pulmonary is many sleep physicians are pulmonologists because of the airway, the breathing at night, but it really does overlap with all areas. Another kind of a current active area of research is also the ICU in sleep, even hospital admission in sleep. And if we are turning the lights on, checking vitals, doing this continuously all night, and someone's critically ill, by sleep deprivation, are we making the outcomes worse? So even that's become an area of focus in sleep.
Ashley wants to know, she says, I have so many questions about sleep. She's got a 2.5-year-old and a 10-month-old. So if you have kids, you've been down this road. Yes. I basically haven't slept longer than 5-hour stretches in over 2 years. So what advice do you have for parents? And I don't, yes, please tell us. Give us all the good juice.
That's a huge, there's, the area of sleep medicine does have a pediatric component also. The diagnosis that we see in those is obviously different. There's everything from, we call it sleep onset limit disorder, other kinds of things with the kids. The problem with this is, you have every extreme from let the kid cry it out versus, hold the kid, the back and forth with the toddlers. What is the best way to handle that? We just don't always know. There's pediatric sleep specialists in town that focus on that area. We certainly try to avoid medications in that population, but there are a handful that we even will use in that setting. But really, most of the time in pediatric sleeps, it's a behavioral approach rather than medication. We do sleep testing also, though, in that population also.
It's fair to say, though, that kids will just keep us up at night forever and ever. It'll never end.
And why one kid sleeps so well from the beginning and another kid has never slept through the night and they're 8 years old, we don't have a good explanation for that either necessarily.
Lori wants to know correlation between dementia and sleep apnea.
There is, kind of like we talked about the sleep deprivation in Alzheimer's, there seems to be even a higher risk in obstructive sleep apnea and Alzheimer's or other cognitive, neurodegenerative kind of things. Once again, is it the apnea that's causing that because you have your oxygen is dropping repeatedly through the night versus it's not necessarily causing that? We just don't really know for sure. The one other thing I can say that there's been some research looking at obstructive sleep apnea and risk of COVID, and it does seem to be even the higher rate of COVID in these patients. The factor that's kind of hard to dig into is it the obesity that's very common in sleep apnea patients versus it's the apnea itself. But that does seem to be a higher rate of COVID infection in patients who have obstructive sleep apnea also.
Hey, Dr. Hawkinson, Vicki has a question. Once you have COVID, does the virus stay in your body forever like chickenpox does?
No, I mean, that's a very good question. This does not have a cycle or anything that it incorporates into your body. This is a short-lived acute infection. This is not like chickenpox or CMV or HIV. Very good question, but the answer is no.
Okay, question is, I just got diagnosed with severe obstructive sleep apnea, and an A-P-A-P was recommended. Maybe it's a CPAP. Yeah, A-P-A-P. Maybe it's a C-P-A-P was recommended. But I received a letter that ordered me a CPAP. Okay, so so there's a difference between an A-Pap and a CPAP?
Yes.
Tell us.
Typically, when patients or individuals are talking about an A-Pap, instead of a CPAP, which I mentioned yesterday was continuous positive airway pressure, an A-Pap is an auto-adjusting. In the last 10 years or so, we've been using a lot more auto-adjusting or auto CPAP, many will call it too. That machine actually can sense airway narrowing, airway closure. It even senses snoring, and the pressure in the machine automatically adjusts according to your airway pressure you need to get rid of the apnea, to get rid of the snoring, maintain airway patency. And that's what most of the time when someone's saying an A-Pap, what they're really meaning is an auto-titrating CPAP.
So, and folks who are just now joining our conversation, we had this is kind of a continuation of yesterday, but tell folks again and remind them about, just in the last 40 years that CPAP has been around, what was the treatment before it came here?
The only real treatment besides trying to lose weight was actually what we call a tracheostomy. You would literally put a tube into the neck, into the trachea, and by doing that, you would leave it open at night, and patients would be able to sleep without having the apnea episodes because it would bypass your nose, your throat, your upper airway, and that was really the only treatment before we had CPAP.
So that's what we call a game changer.
No.
Right? Okay. Elizabeth wants to know, I have sleep apnea and use a CPAP. I've heard of a new surgery for sleep apnea, Inspire. Would you recommend that? Talk about that a bit.
So I did a little bit yesterday also. That's this hypoglossal nerve stimulator, we call it. Inspire is simply the name of one of the devices. There are a couple others that are either in research or in the market also. The idea is it's literally a pacemaker size device that fits on your clavicle, has a wire that runs up your neck into the nerve that controls your tongue function, and you don't even turn it on during the day. At night, you turn it on with a remote device over the pacemaker, over the generator, and at night it stimulates the tongue, protrudes the tongue forward, and by protruding the tongue forward, it keeps the back of your throat open. Most patients, it'll get rid of the snoring also. Most patients, it will help. About 80% of the time, 85% of the time, we cure patients entirely. We do use it in patients that typically have already failed CPAP. We always try CPAP first just because it is what we call the gold standard. It actually will fix everybody if patients are able to wear it. But as I mentioned yesterday, only about 2/3 of patients are able to wear the CPAP long term.
We're going to get to your COVID questions. I see them coming in, but we only have Dr. Stevens a few more moments, so I'm going to try to get to as many of these as I can. Kathy says, it's been decades since I could recall a dream. Is there any relationship between this and my lack of sleep?
There's possibly some. Dream recall, dream content, all that is kind of difficult to interpret. There's patients that have never recalled a dream, and we do a sleep study, and during the study, they may be in REM sleep or rapid eye movement sleep, and that's the stage of sleep that's most strongly associated with dreaming. Now, patients will dream in other stages, and so it's not 100% related to REM sleep or rapid eye movement sleep. But we'll do a study on someone, and they may have 15-20% REM sleep that night, and you see them in clinic, and they still have never recalled a dream. So the fact they don't recall doesn't mean they're not having dream or REM sleep. We just don't really know the importance. There's a few medications that can suppress REM, so your percent of REM, roughly the REM sleep is about somewhere between 15-25% of your overall all sleep overnight. But we just don't really understand why some patients have very vivid dream recall, some patients have intermittent, and then some patients will have just no recall, basically their entire life.
We need to do a dream show. I'll wake up from a dream and say, that's the best dream ever. And I could get to the top of my stairs, walk down the hallway, and it's completely out of my mind. I can't, I'll sit there and go, wait, what was I just saying? And I can't even recall one detail. It's so bizarre.
Patients that really want to recall that, one of the things that there's been some research is start keeping a journal.
Yeah.
And if you start doing that, at 2 a.m. you wake up and you have a dream, to write it down, And patients quite often will start having more significant dream recall their details of the dream and stuff like that if they start a dream journal, but that requires you to wake up at 2 a.m. and write it down.
Which you probably wouldn't necessarily recommend for great sleep, right?
Some patients are just interested in their dreams. So.
Yeah, it is a fascinating topic.
Well, why we even dream is a whole topic in and of itself that we don't understand at all. You know, is there truly a function of dreaming? And the whole sleep community kind of goes back and forth that, you know, it's a way you work out different, you know, exposures, trauma, stress during the day. Other sleep specialists don't think it really has any function at all. It's just a artifact of, you know, evolution of the brain, stuff like that. We really don't understand even the function of dreaming, though.
You know what? That means you're going to have to come back. I'll give you a little break, though. Okay, so Melissa has a question. We talked about this CPAP recall yesterday, so that's what this question is about, and it's affecting many, many people. But Melissa says, my husband's a police officer who had slight AFib. He took meds for it. He got COVID at work before vaccines were available, had pulmonary emboli, I don't know.
That's blood clots.
What did you call it? As POTS?
Blood clots.
Okay.
Pulmonary embolism. Blood clot.
So he was in the hospital for a week. So his job, of course, is high stress. He does shift work, crazy hours. His lungs fully recovered, but now that CPAP is recalled. So how is this going to affect his recovery while he's waiting for that replacement?
We really don't know the significance of this recall, unfortunately. Like I mentioned yesterday, it was simply a letter sent out by the manufacturer, Philips Respironics, saying that whenever the FDA started looking at the machines after they had just a handful of reports, and the number of patients that reported was less than 0.5%. So there's very, very few patients even noted anything. Then they started looking at the machines, and like I said, there's kind of two things they found. There was a gas that was emitted from the machine that could be of concern, and there were microparticles that they could pick up, noted that was coming through the mask, through the hose. The significance of that, we just have no idea. Like I said, you would probably think it's probably not a major issue other than the fact you're sleeping 8 hours a night for months, years. So if you add up that cumulative time for that long, could it really have true health consequences? We just don't know. What I tell all patients is first of all, the doctor that ordered your CPAP machine, reach out to them, reach out to the medical equipment company that sets you up with the machine, and then register the device on the Philips Respironics website, because that's really how you get into the queue of being next in line for the replacement, the repair.
What a hassle, though.
It's
that doesn't sound like any fun.
No, it's not.
Joyce wants to know, what if you need a CPAP, but you're unable to tolerate the mask?
That's a lot of what I do in my clinic itself. There's a few different things that we try. Like I said, there's so many more masks. You know, whenever we first came up with CPAP 30, 40 years ago, there was literally just a couple masks. Now we have dozens. There's different styles, different models. I have patients that we use a desensitization protocol, we call it. You know, if you think about it, you're trying to lay down and go to sleep and put a mask on, which it's not, you know, kind of natural to sleep with the mask on anyway. And then it's whenever you're trying to sleep, you're trying to put it on. So quite often I'll have patients that try to use the mask watching the news in the evening, sitting in the living room, sitting upright. Some patients, even that action of going from upright to laying down really irritates, bothers them. So we have a protocol that we use, and then sometimes I just have patients go back for a refitting. And then, like I said, this is in the situation where sometimes the mouthpiece, sometimes the Inspire, the nerve stimulator. So we do, have other options also in that scenario.
Is sleep apnea reversible? Like, could you?
Mainly losing weight. Like I said, when we were talking with Dr. Stites yesterday, he's got a normal weight, so there's basically nothing.
And he has sleep apnea and is on a CPAP. I learned something new about him yesterday. So he's on a CPAP machine each and every night. So
unfortunately, there's just not many options for him because, like I said, he's kind of stuck with this process that he just can't maintain his airway patency at night while he sleeps. Patients that are overweight, if they lose weight, can improve it, sometimes even resolve it entirely. But really, there's very little a patient can do themselves other than trying to lose weight if they are overweight.
Okay, so this is like a lifetime as far as we know it.
For many patients, yes.
Okay, I'm going to give Tanya the last question. It probably applies to all of us, but does caffeine really keep you awake? I think it's just a habit for me to have her Diet Mountain Dews a day, but tell us a little bit about how to back that up so that we can sleep properly.
There's definitely research that shows that caffeine can interrupt, delay sleep, decrease total sleep time, increase arousals at night. But you really have to look at acute versus chronic caffeine use, because many patients that I see that are chronically using caffeine literally can drink a cup of coffee and 30 minutes later go to bed, lay down, and sleep 8 hours, and there's no consequence at all. So always whenever I, counsel a patient about caffeine use and sleep, the first question is, what is your sleep problem? If the patient truly has no sleep problem, then I actually don't really, get into the whole caffeine discussion to any large degree. Patient that does come in is either has new insomnia, chronic insomnia. That certainly is one of the things to focus on. But every patient's different. Every scenario is different. Like I said, if you've got someone that's chronically using versus acutely using, there's some patients that cutting back into caffeine that can help, but there's many patients that do that and it just doesn't have a big effect on their sleep.
Right.
But it's always one of those modifiable factors that's worth trying first, because if it, first of all, patient responds, they get better. If it avoids a medication, it's worth it.
Dr. Stevens, do you have perfect sleep habits?
I do not have perfect sleep habits.
Do you?
I have reasonable sleep habits.
What can you reveal? Is there? Are
no.
you must be a coffee drinker.
I drink coffee. Yeah. But I don't really have big issues with insomnia. The biggest thing is I've done shift work and called at night from the ICU and the sleep lab and stuff. So I will intermittently kind of have, and I'm just like a typical patient, something's going on, personal, work, stress. I don't sleep as well. The weeks I'm in ICU service, I certainly don't sleep as well. So
you're like a real person.
I'm like a real person.
You're a real person with real problems. I get that.
Yes.
Okay, now I promised you, I said, if you come back tomorrow, I will let you go in time to get to your patients by 8:30. So I am going to keep that promise, but will you just give us some final thoughts as you sneak out of the studio today?
The big thing about sleep is, in the end, it's a lot of common sense, and patients that kind of come in, and I can tell you how many patients they say, while I was sitting in the room waiting for you to come in, or while I'm driving, I suddenly kind of realized what we talked about yesterday, that, I'm only sleeping 5 hours a night because I'm trying to get that thing done before I ever get into bed. They realize that they're not getting enough sleep. They realize that one night they're going to bed at 8 o'clock because they're tired. The next night they're going to bed at 1 in the morning. Mm-hmm. So there's just a lot of what we do is common sense. So keep your bedroom dark, quiet, keep the same bedtime, keep the same wake time, avoid the electronics at night, and like I said, a lot of it in the end is common sense.
Easier said than done, but really great
done.
advice to remember if we can try to implement some of those good habits. Dr. Stevens, have a great weekend. Thanks so much.
Thank you.
All right, I'm going to turn to our virtual guest. So Dr. Hawkinson is joining us from Florida, and we've got Chelsea with us for the Community Blood Center. And I want to talk to you, Chelsea, a little bit about something. If you've had COVID, how long do you have to wait to donate blood? Somebody who's had COVID may think that they can't.
Yeah, so if you have had COVID and you've made a recovery, it's been months, you're welcome to come in and donate. If you've had it more recently than that, we do suggest that you do not come in to donate until you have been symptom-free for 14 days. We know that's a little challenging with COVID, but it's how we do it here. It's what the FDA recommends us to do with our donors. So 14 days after you're symptom-free, please come back and see us.
And let's just lay this to rest. You've been keeping things really safe there for the last 2 years since COVID started. Just remind folks if they have any concerns about COVID and coming in and how you guys are keeping everyone safe. Remind us of that.
Right. So we do still require masks for all of our staff and donors. We're in close contact with donors, so I don't think that that's going to go away anytime soon. A recent development for us is that all of our staff are now fully vaccinated. So we're excited about that as well. Again, donors don't need to be vaccinated to come in and donate. If you did get vaccinated, you're still eligible. Just know that we are still taking this very seriously. Enhanced disinfecting protocols across the board, social distancing, and those masks, vaccines for our staff. We're making this as safe as we can.
All right, Dr. Hawkinson, back to basics. This might have been one from back a couple years ago, but it's a good question. Jeannie wants to know, are all hand soaps created equal? We're going back to our hand washing rules.
Yeah. I mean, the big issue about soap is that it is able to, really destroy or burst open those viruses or bacteria. That is just their mechanism of action, even from soaps from way back, 100 years ago. That's just how soaps work. And so they are all able to clean and destroy certainly everything on the market now, for the most part, from what I believe, especially on the major brands, all act the same, all act to help just destroy those microorganisms on your hand and on your body.
All right, so no secrets. Just wash your hands and use soap.
No.
Okay. Mary wants to know, are negative COVID adults, are they tested for RSV? Do you keep track of that?
Yeah, actually now we do have a multiplex PCR, meaning there are different tests in one test that we are able to do, and we are able to test for influenza A, influenza B, RSV, and COVID-19 all in one swab. We also have a larger multiplex PCR that tests for I believe around 15 or 18 different pathogens as well. That's mostly reserved for hospitalized patients and certain immunosuppressed patients that are maybe in the clinic or outpatient setting. But we do have multiplex PCR tests now that do test for more than just SARS-CoV-2, yes.
All right, Jennifer is concerned about a friend, so let's try to help her out. Her friend is fully vaccinated, but tested positive for COVID. She's feeling really ill and has been bedridden. She spent all day in bed yesterday trying to find an open clinic for antibody infusion and cannot get an appointment. She's very worried about her. Do we have any advice, what she should do, where she should go?
You know, we know the monoclonal antibody access has decreased in our metro area for one reason or another, whether it's the federal and state funding, whether it's the ability to have the workforce and the staffing and the space for those, but also supply of those monoclonal antibodies. So I would just keep trying around. You can certainly try our emergency department. You can call 913-588-1600 for our other infusion center, where we do most of our infusions for the monoclonal antibodies. But overall, around the metro area, there is that just that reduced ability to give the monoclonal antibodies for one reason or another. And I think different sites have different reasons. You know, I would keep, if you are fully vaccinated, and again, I don't know this person that is ill. I don't know what their risk factors are. Do they have age, risk factors? Do they have immunosuppression, other things like that? If they're fully vaccinated, you know, continue that symptomatic treatment with Tylenol or ibuprofen as needed. Keep hydration, keep doing rest, and really just monitor. And if you really think that you are continuing to do worse, then probably seek medical attention at that time and see what else. Maybe there is something else going on, but that's the best advice we could give right now.
Okay. Ross wants to know, any word about a Johnson & Johnson booster?
You know, we know that J&J, you can get your second dose if it's been 2 months after that first dose of J&J. And so I don't know if there's anything more to that question other than that. We know that second dose of J&J has been recommended if you had your first dose at least 2 months ago.
All right, Chelsea, Melissa has a question for you. I have a friend that is O negative. She has regular appointments to donate. I'm A positive and never get contacted from the blood center. Are blood donations from someone like me helpful at all?
Yes, the short answer, yes. The long answer, O-neg is what we commonly use, what our hospitals commonly use in emergency rooms and emergency situations, because that is the universal blood type, which means everyone can receive O-neg. So your friend who has O-neg probably gets contacted by us quite a lot. If you have not donated blood with us before, that could be why you're not being contacted, because honestly, we're pulling all our levers right now. So all of our donors pretty much are being constantly contacted. We do need all blood types right now. We also need other donation types as well, not just blood. So platelets, that's another blood product that we collect here at Community Blood Center that is used for a lot of things in hospitals. So platelet donations are beneficial as well. And your blood type doesn't matter as much with a platelet donation as it does with a red blood cell donation.
The other question, do you get paid to give blood?
No. So in the United States, if you are collecting a blood product that will be transfused into a patient, you cannot pay them. We have to use voluntarily made blood donations. Now, you can, some plasma centers will offer money for your donations because that's commonly being used to create medicines. It's very rarely being used to directly be transfused into a patient. All the blood that we collect at Community Blood Center is directly for patient transfusion, so it has to be voluntarily donated.
Are you concerned this new variant's going to keep people away, or is it just business as usual? Constantly calling people and asking them to come in?
Yeah, absolutely. With the Delta variant, when that came about, we immediately saw a drop in donations and actually had to go on emergency appeal back then as well. So when we started hearing rumors about this new variant, it definitely perked our ears a little bit, and we became pretty concerned pretty quickly when our blood donations started to drop. It's not surprising, but we do know that COVID fears still carry a lot of weight right now, and a lot of our donors are staying away because of that.
Well, before I get to Dr. Hawkinson, and for those who might be just joining us, tell people where they can go. Make it easy as possible for people to come in and give that gift.
Yeah, so I would suggest you go to savealifenow.org. That's where you can look up locations near you via zip code. Also, we have 7 donor centers in the Kansas City area, including one in Topeka and one in St. Joseph. So if you're out in those rural areas as well, we've got some donor centers out there, plus lots and lots of community blood drives. So please go online, look up your zip code and find locations near you and make an appointment there.
Tanya has a great question. I have no idea what my blood type is. That might be, I always forget sometimes too. How do you know? I was told years ago I could not donate because my blood pressure was a little high and they thought I might be borderline anemic. So should I try again? That was like 30 years ago, she says. So is it okay to just come and reapproach and try to donate again?
Yep, definitely. If you don't have any health conditions concerning your blood pressure right now, we definitely encourage you to come in and donate, give it another shot. If you do have some health conditions, just ask your doctor. Most often, a blood donation isn't going to affect that. However, some people's blood pressure does go up. It's a little bit of that white coat syndrome when you're walking into a donor center and seeing people ready to stick a needle in your arm. So we understand that if you are deferred, and in the past, you might not be deferred now. So we do encourage you to come in and donate. When you do make a donation with us, your very first donation, we will send you a donor card that does have your blood type on it as well.
Okay, question. So you mentioned O negative being kind of that universal blood type, but is there a very rare blood type that you are looking for? Is there a rare type?
Yeah, not necessarily rare, I wouldn't say. In the United States, the most common blood type is O-pos. Rare blood types actually aren't usually needed as much because not many people have them. So right now, the big one is O-neg. We constantly are in need of O-neg, even when we're not in a blood emergency. But right now we need absolutely every single blood type across the board. We're low on them all. So we do need any type of blood. Please come in, donate blood.
Isaac wants to know, Dr. Hawkinson, all in all, do you think that the at least one dose number, those people who have had at least one dose, will translate into just fully vaccinated at some point? Do you think that at some point we'll just go, that's good enough?
Yeah, I don't think that if you haven't been infected, we know that if you had infection and then got at least one dose of vaccine, you have really good immune response, both in T cells and B cells. That could be a consideration. But for just getting vaccinated, I don't believe that. And, in fact, I think the way we are moving is that we are probably moving closer to at least 3 doses to be considered fully vaccinated. But I don't think just one dose. I think one dose will start to offer you some protection. We know that occurs. It's not optimal protection. But you will start to gain some protection from at least one dose of those mRNA vaccines. Obviously, for Johnson & Johnson, the original studies came out and said, one dose, and then you get that second dose at least 2 months later. But I don't believe, we are going to be going backwards as far as if you've never been infected and then just getting one dose of the mRNA vaccine, you'll be considered fully vaccinated. No.
Well, yeah, that's tough because you want to say, yeah, one is better than none. Of course, we know that,
Yeah,
but
absolutely.
that's not what we want. So it's a tough message to go between. Okay, a couple more questions, and we're going to do some final thoughts and pictures of cute kids. Okay, so Catherine is asking a question, Chelsea, that I think you already answered, but just in case she missed it, you should wait 2 weeks after vaccination, or you said after a COVID diagnosis. This is 2 weeks after vaccination before giving blood. Would that give your body time to get back to normal? So you said wait until after you're no longer symptomatic with COVID, but what about after you've had your vaccine?
So actually, there's no wait time for after you get your vaccine, as long as you're feeling healthy and well. So we do understand that a lot of people may not feel the best after they get their vaccine. That's okay. You can't donate blood if you don't feel well. That's across the board. So we just encourage you to come in whenever you're feeling okay. If you get your vaccine today and you feel fine, come on in and donate today.
Okay, Rebecca is curious if the monoclonals will still be effective against Omicron, or will it need to be reformulated, Dr. Hawkinson?
Yeah, I think we are still trying to understand and learn that. We know that the Eli Lilly monoclonal antibody was not effective against Alpha variant when that was predominating. We know when Delta became the more predominant, that monoclonal antibody then showed, or the monoclonal antibody at that point showed activity against Delta, and we can use all of the current monoclonal antibodies against Delta. I think we are still trying to understand and learn exactly what the activity of all of the companies' monoclonal antibodies are against Omicron. So hopefully we'll get some of that information soon. I thought I did see some blurb or headline or quote that there is still going to be some activity of at least one of those monoclonal antibody companies against Omicron.
All right, that's going to wrap up our questions today. So Chelsea, I'm going to start with you. I want to get some final thoughts. Again, just your message you want us to head out into the weekend. Let's get a jump start on your push, your campaign to get more blood into our blood banks, and just again remind people where they can go.
Sure, yeah. So I do want to start by saying we're aware that there is some donor fatigue about these emergency messages. We've been in an emergency state for 19 months now. So we do know it gets old to hear from us. But when we drop to emergency levels, our duty is first and foremost to our hospitals and our patients. And we have to go on these very public appeals and approach the situation with some seriousness. So we hope you hear this message and that you don't roll your eyes and say, well, of course you're in another blood emergency. It is pretty serious right now. We've been in a blood shortage for a while, but when we drop to emergency levels, that's when it gets a little more alarming for us. So please, if you are eligible to donate, please go online to savealifenow.org. Make an appointment there. You can also find information about whether or not you're eligible to donate. If you have questions, go to our website as well, or give us a call and we can help answer those questions for you. Please don't self-defer. Don't assume that you can't donate blood. Most people can, and they don't know that. So please come on in and donate if you can. We do appreciate it.
Chelsea, we appreciate you. I know it's a tough job you got, but I know we're in a tough spot. So thanks for coming on. Come back anytime. Okay.
Thank you so much.
Have a wonderful weekend.
Thanks. You too.
Dr. Hawkinson, you got a little halo around you. What's going on?
Yeah, this is I got Delta variant behind me with all more of the RNA packed into it. So it's pretty interesting. It's a nice little cartoon. I think it's from Science, one of our medical science journals. A couple things. I would echo Dr. Stevens' thoughts. There's not a lot we can do for Dr. Stites. He is who he is, so we try to help him as much as he can.
Just in general, with all of his things.
Damien he'd like to know that I have my 2 cups of coffee here. But please, if you have sleep problems, please come to the University of Kansas Health System. Try to get in to see Dr. Stevens and his colleague and his team. They will definitely give you some help. Overall, we know that before Omicron, the Delta surge, the cases for the past few weeks, at least the identified cases, we know those have been going up. I think we are starting to see those hospitalizations now, the consequence of those increased cases. This is before we've identified any Omicron in our region. But I want everybody to stay calm. We know what can protect people from coronavirus, SARS-CoV-2, and that is those non-pharmaceutical interventions, masking, distancing, staying out of those high-risk situations such as indoor gatherings, things of that nature, areas where there's poor ventilation. Continue to use good hand hygiene. Most importantly, get vaccinated. We don't want to get into too much minutia, but I think we still do expect the vaccine immunity to reduce your risk of hospitalization, severe disease, and death, even for Omicron. We are getting more data and more information on a daily basis, and we will continue to report that to you as soon as that comes in.
Dana, thanks for joining us. Has your son played his soccer games yet?
No, he starts today, tomorrow, and Sunday will be the last game. So, but at least I'll get to be outside, and I will wear sunscreen so that our dermatology colleagues don't scold me.
That's right. Okay. Well, I'm just glad you're having time off to be able to go down and hang out with him and cheer him on. So good for you guys. Good luck. Stay safe in Florida, and we'll see you back here on Monday in KC, okay? Bye. All right. And again, thanks to Chelsea. So we want to take a look at some pics that were sent in. Thank you for doing this, by the way. Here is Jacob. Do we have Jacob? There he is, 10 years old. He's a type 1 diabetic. His mom is just so grateful for their doctors and that her boy is now better protected. So way to go, Jacob. We appreciate that. And then we have Lori's 11-year-old. He received his first Pfizer jab last Wednesday. A little thanks. This was the day before Thanksgiving. So a little seasonal gift, the gift of protection and better health. So again, thank you, kiddos, for leading the way. And you can send in those pics and little videos of your kids getting their shots. You can send those to medicalnewsnetwork.org. We love showing off your kids, showing off their arms. So send those in. And thank you so much for being with us today. We really appreciate it. On Monday, how to better care for our bodies and our minds for the holidays. We're going to head out to our Sports Medicine and Performance Center in Overland Park, where an exercise expert, he's going to show us some ways to keep off those extra pounds. And then we're going to team up here in the studio with a psychologist with great advice for coping with the anxiety and the stress of the holidays. We kind of want to end a good year and start a new one on the right foot. So everyone have a great weekend. We'll see you back here on Monday at 8.
Subscribe to our morning medical update and open mics with Dr. Stites podcasts. Now everywhere podcasts are available.